meeting.
Good evening.
Good evening.
I guess
Good evening. Good evening, everyone.
Good evening.
Barry, can you hear me?
Oh,
You can open us up then, like your usual fashion.
okay.
On the very great evening.
You hear me?
Yes, go ahead.
Okay. Our God and Father, we thank thee for all thy continuous blessings and mercies on all thy creation. We thank thee for thy blessings on the Cancer Society by way of continued excellent leadership, a board of directors, office staff, our committees, and especially the benevolent hearts of those who have and still do contribute their treasures. Now, Heavenly Father, we beseech thy blessings on Dr. Wesley Francis, our breast cancer awareness presenter for today. These all are the blessings we ask through thy Son, Jesus, Savior. Amen.
Thank you very much, Mr. Barry. As you know, October is our Breast Cancer Awareness Month, and this month we're having Dr. Wesley Francis speak to us on a topic that will be very interesting. In addition to that, we're going to have a testimonial from a breast cancer survivor, and she will be introduced a bit later. But today's meeting, as well as a meeting we're going to have on October 20th, is sponsored and help from the Royal Bank of Canada. So we have to give them recognition for that sponsorship. And we thank them for all their hard work and effort they give us throughout the year in terms of assisting us in our programs. So we have tonight Dr. Westley Francis. He's an oncologic surgeon, both at the Princess Margaret Hospital and at a doctor's hospital. He's presently the chief of surgery. He's thanking me every day for that. And tonight he's going to be talking on genetic considerations of breast cancer. Dr. Francis, it's all yours.
All right, thank you. Can everybody hear me?
I can hear you.
Yes,
Yeah,
we can.
okay. All right,
Yeah.
so thanks, Dr. Shea, for that warm introduction. And today's topic is a bit different. It's when I first saw the topic, I saw, it had to do more with genetics, and I kind of know the audience for this group. I didn't want to get too technical. So we're going to try and mix it up with the genetic considerations because it's something very important in our community and has a significant impact on the number of breast cancer that we have, and also the type and the way, the presentation. So we'll try to just sort of go through that and also highlight what I think is important to this group at the end of all of the genetic stuff. I think is something that is real important to this group, or should be important to this group. And so we'll talk about screening and the importance of screening in our context. So basically outline again, breast cancer incidence, genetic factors, just some factors that are unique to us, to our breast cancer, and just to show you, kind of the patterns of breast cancer in my practice and the overall outcomes that we see. Well, this is a typical disclosure slide. Dr. Shea didn't decide to pay me today, so I have no disclosures. So when we look at worldwide, and this is a slide of breast cancer, and you can see the different shades of blue all over the world, and you can see North America and Australia particularly Australia, is really dark blue. And you wonder where Bahamas fits in this. The Bahamas is not, well, I mean, they have us as a little dot on the map here. And the thing about it is that when you look at the numbers in terms of the age standardized rate or the incidence of breast cancer, that means how much breast cancer you have per 100,000 population. That's how you kind of look at it overall and compare different countries. When you look at the world overall, it's like 46.3 per thousand. And you look at a place like China, 36.1 per 100,000. You look at the United Kingdom, it's 93.6 per 100,000. And then Australia, so this same Australia with the dark blue, we're actually now exact at the same rate as Australia. Now, prior to this, I would say to you that we've always had some inconsistencies in what our incidences, but this is data for Bahamas now that I could report from our cancer registry, and I'll show you a slide that depicts that. When you look at the next slide, just to kind of give it again context, I think when you use these bar charts, you tend to see where you kind of, and this is in ascending order. And I had to introduce Bahamas into there, and you can see that we're way up there in terms of the number or incidence of breast cancer in our small country. We have a little over 400,000 people. And you can see that we're really not competing, but outdoing a lot of other more westernized civilizations and countries that are certainly have much more resources than we do. This is numbers from our cancer registry, and this is 2018. The cancer registry, as some of you may know, was just really developed a couple of years now, from I believe around 2016, 2017 is when it was really established. And so the decision was made to collect data going forward. So they had data on 2018, and now 2019 data is about to be published. I happen to have a relationship with them, so I get the data earlier. But this is 2018's data, and you can see within the registry, the most common cancer overall was breast cancer. And I want to show you this, and it's a bit busy, but the top graph here, if you could see my pointer, is breast cancer. Now, really what this graph is showing is the impact of the registry on our data. Now, this is data that would have been collected by the ministry from 1998 up to 2017. And then we added 2 years of data from the cancer registry, the new Bahamas National Cancer Registry. So up to 2017, you can see that, our numbers for breast cancer been tracking along, and it was always around somewhere around 50 average per 100,000. And then you see 2018, and you see up to 101 per 100,000. Now, some of them say, wow, something really happened in 2018. What really happened in 2018 was the registry, because prior to that, all of the data that we were collecting really came out of Princess Margaret Hospital. And what the registry did was started to collect all the private, the data from the private hospitals and also from doctors' offices. And you can see we kind of doubled the rate or the incidence of breast cancer. So it wasn't a matter of this extraordinary increase amount. It was just that we were never recording the amount that we were supposed to. And so you could see in 2 years, in 2018, it was 101. And then in 2019, it's 94.5. And I'd imagine when we get 2020 data, it's probably going to be hanging around the same number. So we are really way up there and one of the highest in terms of the world in our presentation or incidence rather of breast cancer. And that's significant considering our resources that we have. And I would even say that a lot of this is still, we don't capture everything because we're still trying to capture those patients who would have been treated outside of the Bahamas or would have gotten the diagnosis outside of the Bahamas and were not recorded. So you can see that this number can still go north. And I think that this is very important for us to note. So what are some of the factors that affect, certainly genetics, but I also want to mention some cultural concerns that affect the distribution of breast cancer for us. So when you look at, okay, genetics and genes and the amount of genes that are known to cause breast cancer, and you can see it's multiple. This whole page is full of genes that actually can lead to development of breast cancer. But there are only a few of them that actually are what we call high penetrance. So penetrance meaning if you have a mutation, how much, I would put it, what's the likelihood that you will develop a disease? And there are some mutations that have a high likelihood, or rather what we call a high penetrance. And there are some mutations that have a very low penetrance. So you could have the mutation and disease. But you can see from this, BRCA1 or BRCA1 and 2 are at the top, and they tend to be the high penetrance mutations. But they're not alone. There's TP53, ATM, CHEK2, PALB2. They're all kind of different numbers or letters, CDH1. And I highlighted the ones that I think are significant in our population, which we would have seen patients with or which we would have measured. So where did this BRCA story begin? Well, it began some time back where a few of our oncologists collaborated with oncologists at the University of Miami. And they looked at 214 patients, cases of breast cancer. And they then did analyzed their samples, or they actually did what the saliva test on them. And they detected 49 mutations of these 214 patients. Now, all of these patients had breast cancer. And so when they detected these 49 mutations, that gave a startling number of 23% of what we call unselected cases due to found mutations in BRCA1 gene. And up to that time, well, it hasn't been surpassed. That's the highest rate. Now, this paper has often been misquoted a lot because then a lot of people use this paper to say that we have 23% of breast cancer in the community, that or we have 23% mutation in our community, which is not the case. This is just a group of breast cancer patients that they checked. It wasn't patients who didn't have breast cancer. So the prevalence or the amount of mutations within the country is not 23%. And I want to make that clear because sometimes every time in October, this paper is quoted, and I think it's misquoted at times. And so that was just what we call, they just did a portion of the gene, and they just looked for what we call just certain mutations. But then they went on to do a further study where they did the entire spectrum of the gene. And I'll show you a picture of the gene, because they're over even almost the breast cancer. So what they did, instead of just doing a part of the gene, they did the full sequence to see if this continued to bear out. And what they found is that not only was it was much higher, they found more mutations. And so then the number went from 23 to 27%. So that initial 23 was just specific mutations they were looking for. But when they look at the entire gene, they actually found more mutations in those patients. So it was real. And so this is what kind of put the Bahamas on the map. This is where this whole BRCA1 story began. So what are founder mutations? Because what they did in the initial study was they looked at just these, what we call founder mutations. And I just want to define it so that people can understand what we mean by that. And founder mutations is really a genetic alteration. And we say germline meaning it can be passed from parent to child. And it's observed in a population with high frequency that is or was geographically or culturally isolated, in which one or more of the ancestors was a carrier of the altered gene. So this is what is called a founder mutation. And as you can see depicted in the little picture cartoon here. So this person would be the founder, and this is the mutation that is passed on, and is germline because, you know, each, our genetics, we get 23 from father and mom, and then it can be passed on. So these two inherited this mutation. Now, there are other founder mutations in diseases, and some people may know. I think the one mutation that most of you may be aware of, especially in our community, would be sickle cell. So sickle cell is passed on. The sickle cell gene is passed on the same way. And the thing about it is that the sickle cell gene in a trait state is supposed to be protective for people against malaria. And so that started in Africa. So there's a whole theory that BRCA in a carrier state, because there are no patients out there who have both genes mutated. They only have one gene mutated, and that's the ones that cause disease. If they got two genes mutated, that person would not survive. So again, sickle cell is when you have both genes and you got what we call a homozygous, then that person survives. When that person survives, that person gets sickle cell disease. But in the carrier state, that person has a mutation that protects them. And again, we all came ancestrally from Africa. In Africa, sickle cell actually protects patients, or the sickle cell trait protects patients from malaria. So at some point we're starting to think, well, what is the protective factor for BRCA? Because what we've seen is these are carriers. These are the ones who go on, because of the high penetrance of BRCA1 and 2, they go on to develop breast cancer. Now, is there some sort of benefit to that? And that's something that is still being explored, because the whole concept of founder mutations is that as it is passed on, there should be some protective benefit from the mutation. So when they, so this was something actually somewhat unique to us, because when the same group of of researchers from University of Miami. They tried to see if they could duplicate this thing in Trinidad. And what happened is that they didn't find the same amount of BRCA1 as in Bahamian women. They found a much less, 5.6% overall, whereas with us, it was somewhere of 27%. But what they found is other genes, and this gene is called PALB2. And so this is one of the genes that I showed you in the list that also has a high penetrance, and it goes on to lead to breast cancer. And they did the same thing in Jamaica. And again, they had 179 patients that they looked at, and they found BRCA1 and BRCA2 was only 1.7%. But yet this PALB2 gene, they found to be 2.8%, which was highest reported to date for any population. Even we in the Bahamas don't have this amount of PALB2. So when you look at it, what's unique to us is the BRCA1. We have the highest prevalence as shown in these studies. And it was not like it's a regional thing, it's a Bahamian thing. So, and that is what makes our pattern of disease a bit unique. And so a colleague of mine, Dr. Patrick Roberts, we both of us do genetic testing in our practices. And we decided to compare notes. And I said, listen, why don't you show me yours and I'll show you mine. And so he had 27 patients and we had 46 patients, all of which we did this multi-gene testing. And this was full sequencing gene. Just to compare, just to see whether this was following through, whether is the Bahamas different, really different genetically from Jamaica on the rest of the region. And so we decided to just do this little study. And these were the genes that I analyzed. I mean, you can see here, and we tested pretty much 84 genes to see if there was a difference. And these were all patients who presented with breast cancer, or if they had a first-degree relative who was known to have a gene and they wanted to be tested. So before I show you what Jamaica's had, this is what we had. Now, when you look at these genetic mutations, some of these genetic mutations cause disease and some do not. And so when we say they are pathogenic is the ones that actually cause mutations. So for example, a BRCA1, if there's a pathogenic mutation, meaning a mutation that actually is known to cause a disease, then we label that as pathogenic. There can be other mutations within the gene, within any gene, and we call them variant of unknown significance or uncertain significance. They don't cause disease, it's just the mutation. And so when we looked at our data, we found, and this was interesting, we had a lot of the different genetic mutations, just as you saw in that complete list. We had ATM, we had POL, we had, of course, BRCA1 was the highest amount that we had, but we still had all of these different ones. PALB2 we also had, but all of these that we had, they were the non-pathogenic or the variants of uncertain significance, meaning they didn't cause any disease. But they were here, but they didn't cause disease, or they were not known to cause disease. So, but when you looked at those that caused the disease or the pathogenic ones, 87% of them was basically BRCA1. So in the Bahamas, when you look at pathogenic mutations, meaning the ones that cause disease, the majority by far is because of BRCA1. And so we knew that because we did our little internal thing before we compared it to. And then when we compared ours to then Jamaica, well, you can look and see they had pathogenic mutations way across the spectrum. They had pathogenic mutations in ATM. They had pathogenic variants in CDH1. They had BRCA, but only small amounts of BRCA. And you can see they had TP53. But we, on the other hand, we only had BRCA1 and BRCA2. Even though we had a lot of variants, it didn't cause disease. So again, it showed the uniqueness of the Bahamas. And so our genetic story is real. And we proved that with the initial studies that they did, and even our study between Dr. Roberts from Jamaica and ourselves. And so what does BRCA1 really do? And when you look at it, you could see the population risk versus the risk that you get from BRCA1. And again, we have male breast cancer, and the majority of male breast cancers, or a significant amount of male breast cancers, are because of BRCA1. Pancreatic cancer, and we are seeing a good amount of pancreatic cancer. And again, BRCA1 increases your risk from 1 to 3% over the general population. Prostate cancer, we have our fair share of prostate cancer. And again, BRCA1 increases that risk of prostate cancer. When we look at ovarian cancer, when you look at the general population, it's just 2%. But if you have BRCA1 or BRCA2, that percentage goes way up. And then, of course, with breast cancer, it goes way sky high. So in your lifetime, someone with a BRCA1, their risk of developing breast cancer is 40 to 87%. So you can see how BRCA1 influences our spectrum of disease. And because we know that it's more prevalent in our community, therefore you can see that it influences or shapes the pattern of disease that we get. We get a more aggressive prostate cancer. And we know that the breast cancer that attributed to BRCA1 are more aggressive, tend to be more common in younger women. And the same with ovarian cancer. And so this is how this gene influences our community. And it's unique to us. Why is this so unique to us? I don't have the answer to that. And I'm certain we need more research into that, but it's so unique to us, and it truly influences us. One of the studies that we would like to do is, because we're starting to see a lot of pancreatic cancer, although we see them late. One of the things that I'd like to do, if we could get some funding for it, is to test those patients to see if it is really truly that BRCA is what is causing those cancers to be more prevalent. And so let's look at this mutation, and let's look at the spectrum of breast cancer. Breast cancer has a spectrum where, again, and I tell patients this all the time, one cap doesn't fit all. And the term that we use in breast cancer is that it's very heterogeneous. I tell patients that if you have breast cancer, your breast cancer may behave very different from someone else that you know. Even among families, it behaves differently. And it's because there are different subtypes. And so the behavior is influenced by the subtype. Now, when you look at the subtypes in terms of more aggressive versus less aggressive, when you have this BRCA1, these BRCA1 breast cancers tend to be more triple negative. And again, they tend to have the worst prognosis. And so we're starting to see now, yes, what's our influence? We have all this BRCA in the community. So therefore, those patients who have BRCA, when they do present, they present with triple negative breast cancer. And not only that, they tend to be younger women. And so we start to see that that curve for age of presentation gets pushed down, which should be in the 60s, getting pushed down into the 50s or into the 40s. And so we start to see much more younger women with more aggressive tumors. Now, the only silver lining in all of the BRCA story is that triple negative breast cancers tend to be much more susceptible to or much more responsive to chemotherapy. And so we're seeing where people who present with triple negative breast cancer and who may have this BRCA gene, because we sometimes we can't test everybody resources because of funds. But when we see this triple negative type, which is common in our community, we know that they tend to be more sensitive to chemotherapy. So the treatment options for them should really has changed over the course of the years. And we're starting to initiate chemotherapy with them much earlier than we would somebody who does not have a BRCA1 or triple negative type. And you see, if you do that, you actually tend to get better results with these triple negative breast cancers, because a good percentage of them will actually wear what we call a complete clinical response, meaning that some of them will actually, the breast cancer will disappear within the breast. And when we see that, we know that that prognosis of that person is very good. So if we go back to the discussion where we had, where that carrier state protects people. We said with sickle cell, a carrier state of sickle cell protects the patient or the carrier from malaria. So perhaps the same thing is true for this BRCA1. And because it's such an aggressive type of breast cancer, the fact that it's more sensitive and more responsive to chemotherapy, that may be the silver lining. And therefore, it's important for us then to know that they have that breast cancer or the BRCA gene, because knowing that, then you can treat them in a different way and thereby alter the path or the outcome of that patient. And so I think that's where the story of BRCA is going to develop. And I'm hoping that we in the Bahamas will lead that to show that that may be the reason why patients who tend to have a worse prognosis also tend to have BRCA. And if that's picked up or we test and we know, then we can treat them in a different way. So we should get genetic testing. Well, anybody presenting with breast cancer, and it goes age-based. Well, if you're under 45 and you're presenting with breast cancer, we should get tested. Because again, we know that BRCA1 and BRCA2 tend to have patients who are much younger. Well, if you're between 46 and 50 and your family history is unknown or limited, if you have multiple primary breast cancers, and what I mean by that is that you have more than one breast cancer within the breast, or bilateral breast cancer. You have left and right breast cancer. Certainly that's the pattern in which BRCA presents, and so those patients should get testing. If you're over 51 and you have greater than one close relative with breast cancer at age less than 50 or male breast cancer, then certainly. Or if there's ovarian or pancreatic cancer within your family at any age. And then if we don't look at age-based, at any age, anybody presented with breast cancer who has triple negative breast cancer, and this is why it's very important for us to know the hormone status, not just the histology, not just to know that you have breast cancer, but to know the subtype, because then it really influences the treatment. Because if you have triple negative breast cancer, or rather, I'll put it this way, if you have breast cancer and it is then known that it's triple negative, chemotherapy should be initiated before even surgery in those people. I think we tend to be a more surgery first kind of country. But now, when you look at the different variations or the nuances of breast cancer, then we have to realize the role of chemotherapy is that much more important than surgery in patients with triple negative breast cancer. So how does culture influence our breast cancer? So we kind of moving away from the BRCA story a little bit, and want to talk more about things that I see and what I believe that we need to focus more on. So religion really affects treatment delays, the waiting on God to cure. I'm not a blasphemer. But we see a lot of patients who knowingly have this thing in their chest, growing and growing and growing. And they said they prayed and they're waiting for it to go away. And so therefore they come late. Believe in natural remedies. I am not against natural remedies, but natural remedies alone without conventional therapy is pretty much a death sentence. And this is just my personal experience, which I've seen. Dr. Sheikh can maybe speak about his experience, but when you see people saying, oh, they're going to just go and get natural remedies without the remedies from, without the conventional medicine, either chemotherapy, surgery, radiation, they tend not to do very well. The fear and embarrassment culture, which lead to a construct where women tend to hide and they allow these things to just grow. And they do not share this information with their relatives. And so what would have been initially something small, and I mean, I hear it all the time, I heard it last week, turns into something blossom huge because of I didn't want to talk to anybody about it. I was ashamed about this. I mean, the breast is a very personal organ. So we still see this. I mean, this is very graphic. I apologize for what this may be, to some folks, but this is what we see sometimes. We still see this. This is 2021, okay? In Bahamas, I mean, we still see this. I saw one of these last week. I don't have that picture. This is an old picture, but we still see this. Now, I'm putting this up here so that just to give an understanding, and I will use I will compare breast cancer to colon cancer. So in colon cancer, you develop polyps, and then polyps go on to become cancer. And so if you did a colonoscopy and you find the polyp and you take the polyp out, you prevent breast cancer. Sorry, you prevent colon cancer. Because it's a continuum. Polyps go on to develop cancer, okay, colon cancer. The same kind of happens in breast, where you get abnormalities starting to happen in the ducts, and the ducts the ducts are where, for example, when the milk is produced and what we call the lobules, and then the ducts, they guide them down to the nipple, and that's where the baby sucks. Okay, so most breast cancer occurs in what we call the terminal ducts. And what happens is that you start to get 1 or 2 cells that become abnormal. And this takes time. We don't exactly know how long this takes, right? But it takes time. And it gets to this point where it's called DCIS. And what this is non-invasive breast cancer, okay? Where you get these cells like this. Now, there's a time before when you see this, before I get to what we call invasive. And as the cartoon depicts, what happens is that these cells break through the wall, and it breaks through the wall, and well, the horse has left the gate. But when it's in this phase right here, okay, within these cells, and when you take an X-ray, you can see that calcium deposited within that cell. Essentially, that is what mammograms pick up, okay? Now, I want to show you this. Now, this is essentially my practice. I've been practicing for about 10 years now, well, 11 years. And I want to tell you that this is not my PMH practice. I have a PMH practice and I have this. This is my private practice. And we looked at the stage of breast cancer that when patients present to us. And this is, to me, when I saw this, it opened my eyes a bit. I mean, I saw it, but I never saw it when we put it on paper. And so most of our patients actually present at stage 2. And when we say stage, that's when they have a lump in the breast, a lump under the arm, or some sort of change within the breast that you can detect physically. Now remember, but you want to pick up breast cancer when it's at stage 0, or this DCIS stage. And I'm gonna go back here because you want to pick it up here. And because the calcium is within these cells, you want to go back and then do a mammogram. And this is called screen detected breast cancer. Now, this is the percentage on stage. Now, I want to show you now why I specified that this is my private practice is because these are people with resources. The patients who come to my office. Patients who come to my office, they have resources. Okay. And so you could see that we only had about patients who presented with DCIS or who had a breast cancer that was picked up by mammogram. Now, this is very different from someone who comes in with who feels a lump in the breast. And when they feel a lump in the breast, they go and get a mammogram. This is someone who actually gets a mammogram because they're getting screened and calcification, and they are still at stage 0. And when you look at the outcome of these patients, their outcome is essentially 100% with treatment. But you can see here that the majority of my patients who come to me are patients who have resources, meaning who can get a mammogram. And I can tell you there are about 6 places in the country right now that you can get a mammogram. It's not for lack of resources. We don't see a lot of them. What we see is mammograms not being performed for screening, but more for diagnosis. And that, I think, is something that this community and this organization can affect some kind of change. So when you look at our patients, yeah, again, average age is about 52, but you see, we are seeing some young patients. And actually, last night in preparation for this, I was looking at a database from the registry, and for 2018 and 2019, I wanted to know how many patients were under the age of 30. And luckily for us, I mean, I was happy to see there was only 7 of about 400 that were under the age of 20. So, you know, there's always the argument of should we screen earlier, blah, blah, blah. And I mean, that's a topic for another time. But the majority of our patients, a good number, almost 50%, have some kind of family history. And that shows you the genetic pressure within the community. Because the patients most of these patients would have had some relative, either first degree or second degree relative that had some sort of breast cancer. And then when I look at the BRCA population among my group of patients, again, it was very high, 22%. The The good thing, though, was that more people tend to have negative lymph nodes. Again, we tend to be a very, very heavy mastectomy population. And that's something that we ought to try to change, because if you catch breast cancer earlier, and you do what we call breast conservation, and you can see my breast conservation rate was 17%, and I try to push people in that direction, but there's a cultural thing to believe that if you have breast cancer, you got to take this breast off, and that is not true. The survival is basically the same if you do a mastectomy versus if you do what we call breast conservation. Breast conservation is where you remove the lump with negative margins around it, with normal tissue around it, and then you add radiation to it. But a lot of patients, you give them that option, but they choose mastectomy. So let's look at the outcomes, and this is where we're gonna end. But our outcomes are pretty much similar to the US in terms of Black and well, the Black population in the US. And if you look at, this is a curve that shows, you know, whenever someone dies, the curves drop. But this would be more insightful in terms of all stages. 82% of Bahamians, or at least the population that I treat, survive, versus 82 in the US Black population. Obviously, the US whites tend to have a higher survival rate, and that's for very different reasons. And again, you see that there's some sort of comparison between us in the Bahamas. So we're not doing too bad. A lot of people just run off to the States thinking they get better care, but not necessarily. So how do I conclude? We're a unique population. We have a high incidence and prevalence of breast cancer. This increased numbers of BRCA1 carriers can track way back to our West African ancestry. And we need to do more research on that. But this is unique to us. This is not something regional, but this is us. We have some cultural and lifestyle issues that we need to overcome. And that's what Cancer Society of the Bahamas needs to help with. And we really have to put more emphasis on screening. Screening saves lives. Screening detects cancers earlier in that state where those cells are still within the gate and they haven't left. And I think this is the focus that I believe that organizations, non-government organization like the Cancer Society needs to do, and the membership needs to do that and to push that. And again, I want to thank you all for inviting me to give this talk. I tried to bring it down so there's not too much technical aspects, but again, thank you all, and I'll entertain any questions.
Thank you, Dr. Francis. Very informative talk you gave us tonight. Does anyone have any questions? I don't see any questions on the chat. But you mentioned screening. You know, we at the Cancer Society do push a lot of screening. And some may say, oh, since we do screening mammograms at 40, we're going to be missing quite a few. Give us your take on other forms of screening as opposed to just mammograms. Should we do MRI? Should we do other things? What's your take?
So that's a good question. I anticipated that question. So again, I looked at the registry and I looked at how many patients, and again, it was over 400 breast cancer patients over a period of 2 years. And I looked at how many patients were under the age of 40. And what we found was only about 37 of them that were below the age of 40. So if you were to screen earlier than 40, you may miss 37 patients. Now, that may sound 37 is a lot, right? But you think about how many women you would have had to screen to pick that up, right? The other aspect of that one needs to take into consideration is the tool that we use. Now, again, mammography picks up calcifications within the duct. And whenever you get below the age of 40 and younger women, they tend to have very, very dense breasts. And so that density can overshadow that that calcifications, such that it makes it kind of inaccurate. So we're faced with the problem with, well, how many people we have in that younger group? And secondly, is this tool, this mammogram, is a useful tool? Now, some people talk about the addition of ultrasound to help with those patients who have more dense breasts. But what I believe should happen is that it should be what you call screening should be individualized, and people should not just get screening just in the absence of seeing a physician. And as physicians should basically calculate each individual woman's risk of breast cancer. For example, someone who is high risk or is in that population where they have multiple family histories and they're young, then you know that they are at higher risk than the average population. But you're only going to get that if you have that sit down and have that conversation. And this is where an MRI becomes important, because if you find that somebody's in a high risk population, an MRI is a better study than a mammogram, because density is pretty much eliminated in that situation, and you can pick up those smaller breast cancers earlier in younger women. Now, the problem with MRI is that it's expensive. So again, this is why I said it has to be individualized. And in doing so, you get that relationship with a physician. That physician calculates what your individual risk is for breast cancer, and then can assign to you what your level of screening should be. I believe that's how it should be done.
There's a question from the group, the chat. So, excellent presentation, Dr. Francis. What are the insurance implications for a BRCA positive person?
Well, that's a problem still we have in this country. And again, this is where I think organizations like Cancer Society should lobby. I think in the US, there's protection against patients or discrimination of patients with genetic mutations, especially one like BRCA. So we don't have such laws. And I think that this is something that we need to push. Cancer Society need to push. We need to lobby the government. They say this is a new day. Make this a new day by saying, listen, let's bring on some legislation that's going to protect women in our community, seeing that we know that there's a high prevalence of this gene in this community. So again, that's maybe one of the things that the Cancer Society can take on, but there's no laws that protect anybody, and your insurer can actually, if you have an existing insurance, they may not be able to drop you, but certainly if you were to lose that insurance and you try to get insurance, that may become a problem.
There's another question. Is there any recommendations of new equipment or clinic that can check dense breasts? MRI, I guess.
So again, there are two things that I think pretty much all of the mammography imaging centers around who carry mammography have this technology called tomosynthesis, which is supposed to increase the sensitivity of the breast. It's almost like a CAT scan of the breast. And so that's one of the things that can help. But in addition to that, when the radiologist recognizes that you do have very dense breasts, he should order an ultrasound. And I think in a lot of states in the US, it is required that when reporting the mammogram, that the radiologist should indicate the degree of density, and then that should then automatically lead to development or ordering of an ultrasound. I hope that
some more comments. It says, Great information and data shared, Dr. Francis. More research is definitely needed in our country, especially on the islands.
Yeah, definitely.
Yeah.
Oh, I had my video off. I didn't realize. Oh, sorry.
Are there any other questions? In terms of other screening modality, I know there must be some artificial intelligence or some other people working on these, like breath analysis and ductal massage. Can you?
I don't know much about those kind of things. I know that there is a new technology that's starting to come out there. We're starting to see where they use thermography, where they look at the heat signature within the breast. But it has not become standard of care yet.
Right, yeah.
But it is certainly is going to become an adjunct or something in addition to a mammogram. And so if you think about it, thermography is heat signature, and certainly more rapidly dividing cells like cancer cells would tend to give off more heat. And so it's just believed that, that this would increase the sensitivity of the test and certainly get around that density issue.
I read an article the other day about they're now training dogs to detect COVID. Of all things.
I saw that.
The dog's noses are very, very sensitive. So they've had some studies where the dog picked up prostate cancer and all of other types of cancer as well. But that's sort of in preliminary stages right now.
Yeah.
But I must give you, I forgot to mention it at the beginning, but must give you kudos for your development of the Bahamas Cancer Registry. You put a lot of work into that and got legislation also to get that registry going, and kudos to you and thank you very much for that. Can you tell us, tell the public where the actual registry is and inform them about it?
It's in the Eugene Cooper building, and that's on Village Road opposite Kalina. That I think the dental council and some other council are in the building, and that's where the registry is. And I mean, the success of the registry is basically the participation of people who see cases with breast cancer. And so we're trying to get a lot more physicians to start reporting. One of the things that we put in the legislation was to put a fine if you didn't report. But I mean, and I made them put it to $50,000. But nobody's going to go after anybody for not reporting, right? But we hope that we get more people to understand that the more information you give out there is for our own benefit in our community. And so we're hoping to get more physicians to actually report to the registry.
One of you, do you have like infectious disease, you have to fill out a form and report it? Is there a system like that?
Yeah, well, cancer, the legislation made it a reportable disease, but we've been writing letters to different physicians.
Yeah, but the registry itself have a form that we have to fill out to send to the registry? How?
So right now, what they, if they write you a letter and you respond, they'll come to you and take your data, basically. They come to my office all the time, and well, I mean, they get on my computer, take all the information from me, and then go. I don't have a problem with that, right? Because I think that's what needs to happen. And so, but we just need, I think, as the registry matures and this data abstraction continues, more people can understand that it's important to actually send this information out. And also, when we start to put information out there and people see that they can get information out of us, then I think they'll see the value of the registry to them, and hopefully they will report more.
Let me see any more questions. Can you expound on the influence of diet on the risk of breast cancer?
Yeah, so diet. So there are certain things that we know for sure that increases your risk of breast cancer in terms of diet. I mean, like alcohol, we know. There's not any particular nutrients, but then obviously if you have a high caloric diet and you have obesity, there's a kind of So obesity in and of itself increases the risk of breast cancer. So there's not any one food that would say increase your risk, but if you have a diet that's rich in fat and you tend to get obese, obesity on its own creates an environment that's conducive or promotes cancer, what we call carcinogenesis. And that's what we find, especially in postmenopausal women, many women over the age of 50. I mean, younger women tend to be more active. They tend to can control their weight. But, you know, in the Bahamas, we're pretty much one of the, we have a high incidence of obese patients. And I think that also promotes an increased risk of breast cancer in and of itself.
There's another question. How likely is cancer detected with dense breast with an ultrasound?
That's a very good question. So again, remember we talked about the calcifications, yeah? So only if those calcifications form a mass, because ultrasound can't pick up calcification. And so a proportion of the time when you see the calcification within the duct, it then forms a mass. And if it forms a mass, then an ultrasound can pick that up. So the pickup rate is probably, I think the last figure I saw was about 20 to 30% extra. And so that's why we recommend that you do get that.
Yeah. What are the odds of a person being diagnosed with breast cancer after an absence of not having a mammogram for one?
And I say that because, you know, COVID, this is one of the side effects of COVID, or the I suppose, unintended consequences of COVID, because a lot of people missed their mammograms in 2020. Believe it or not, we're starting to see a lot of people now who get in mammograms in 2021, who, because they missed in 2020, are now coming up with some, you know, some lesions in the mammogram. I don't know if you're seeing that in your practice.
Yeah,
but
I have.
certainly seen quite a bit of that.
Definitely. Yeah, when you miss 1 year, some people have a, you know, the biology of the tumor sometimes very high grade tumors, and they can grow out of control within that 1 year. So very important to do the mammograms annually.
Yeah.
A couple comments on the registry. Said why is the registry 2 years behind? And they're giving you congrats
Actually,
on the registry.
Why is it 2 years behind? Actually, that's the best in the Caribbean right now.
Yes, yeah, they always lag.
Most registries are like about 4 or 5 years behind. We do it pretty good.
Gathering information is hard. Yeah.
Yeah, and gathering information, even in a small town like this, is hard. So that's not it's even some U.S. registries are behind like 2 years.
All right. This program is can be reheard on YouTube, but we have thank you, Dr. Francis. We're gonna move on to a little other segment, but stay tuned, stay listening. We have a cancer survivor gonna give us a little of her testimonial. She's actually our administrator of the Cancer Society, and we're gonna give her several minutes to give us her story. Erin, are you ready? Are you ready?
Yes. Good evening, everyone. Yes, I am a 2-year breast cancer survivor, and I usually get my mammogram done every year. And 1 year I missed, but I made it up a few months later, and that's when they detected a lump, and they suggested that I do an ultrasound. I did the ultrasound, and then the ultrasound suggested I do a biopsy. Did the biopsy, and it came back stage 1 breast cancer, ductal carcinoma. At that time, I was exercising and trying to eat right, but I don't know. These things happen, like Dr. Francis says, it's in the genes per se. After consultation, I decided to I did 4 rounds of what they call the Red Devil Kool-Aid, which take off all your hair, your eyebrows, leave you with no taste, you smell, even your touch. After I finished with that, I had 12 rounds of Taxol for my hormones. And then I had 35 rounds of radiation. When person asked me about radiation and, all this I went through, with radiation, I always tell them it's like putting the icing on the cake. Because after you've done surgery and you do the chemotherapy, sometimes there are some little underlying cells that may be there, and the radiation will help kill those cells and eradicate it. So, going through the process, it may be mind-blowing and it's a lot to take in. But if you want to preserve your life and you want to, stay healthy, this is something that it's a personal choice. And I've heard persons, because I've heard Dr. Francis mention about person went the holistic way. I had a friend who did that. She went the holistic way and went away and, dip in hot springs and changed her diet. But her cancer came with a vengeance. And unfortunately, she had succumbed to it. By the time she tried to get treatment, it was just too late. They couldn't, do much for her. So, I always encourage persons, get your mammogram done. Get it done every year. Don't miss, even if you have little symptoms with your breast. It's not always where, you may have excretion from the nipples, because I didn't have any of those. I didn't have no swelling or anything. I just had a slight tenderness, but as most women, you put on weight, so your bra tends to sometimes be tight, especially if you wear the bra with the underwire, which is the bone, which now that I have stopped wearing. But I always encourage, get your mammogram done. And once it's detected in its early stages, it's a new lease on life. Don't avoid it. Don't deny it. It is something that needs to be addressed. And the earlier that you can address it, the better it is. And after going through all of those treatments, who would have known that I would be here at the Cancer Society to speak to other persons about breast cancer or any type of cancer? We all know our bodies, and there are telltale signs that our body gives us for us to go and see a doctor. Don't deny it. Don't put it off, because, this is your one body, and, putting it off can make the situation even graver. So with all that said, also too, get surrounded with persons that will support you, that will encourage you, motivate you. You hear a lot of people say, oh, my cousin was diagnosed with breast cancer, or my aunt or whatever, and they died. And that you become depressed and you feel like, okay, you're gonna die. But that's not always the case. You have to always give this a positive outlook, because getting treatment done, you're fighting for your life. And that's a fight you want to do to enjoy the rest of your life, because we are promised 70. So we want to actually get to that 70. So with that, like I said, I encourage everyone, get your mammogram done. Get it done at a regular. If you don't do it on October with breast cancer, set a time, a calendar to do it every year at that time. But know your body and know when your body is telling you something.
Okay, thank you, Erin. We must thank Dr. Francis again for his excellent talks on genetics, and hope that'll make us more inquiring about what we have, and then we can have more research in that area. Thank you, Erin, for that great testimony. And we thank our sponsors tonight, Royal Bank of Canada, for their assistance in everything we do, and hopefully they'll continue to give us good sponsorship. I must mention that next week, Wednesday, October 20th, we're going to have another virtual forum similar to this. We're going to send out the link once we get closer to that day. And again, we're going to have caregivers give comments, survivors give comments, and we're going to have a male breast cancer survivor as well, hopefully coming on our show, and we'll be welcome to have you join us and ask some questions. So We want to thank all the participants tonight, Dr. Holliday for his technical support again. Are there any other questions before we leave tonight? There's some comments on the chat. Great testimony, Aaron. Very positive attitude, Aaron. Thank you, Aaron. And thank you, Dr. Francis and Aaron. Are there any other comments? If not, we will say goodnight. We actually on a taped program tonight too on ZNS. If you want to leave us and join ZNS, I think it's gonna that show might catch the end of that show. We also want to encourage persons to visit our center. We have T-shirts on sale. We have cancer paraphernalia and our thrift shop. If that is all, we're gonna say goodbye for now and join us next week, Wednesday. Thank you.